We are live, sir.
Hello,
Please start.
okay. Hello, good evening, everyone. We welcome you all for this live webinar on Lung Cancer Meet 2023.
Good evening.
With immense pleasure, I would like to invite Program Convener Dr. Arpit Jain, sir. He is Consultant Medical Oncologist, RGCI, Delhi. Over to you, sir, for further proceedings. Sir, you are muted, sir. You have to unmute. Yes, sir. Arpit, sir? Yes, sir. You can start the proceedings.
Good evening, Satyajit sir.
Good evening. Hi.
Hello.
Hello. I'm audible?
If I am audible?
Yes.
Yes, sir. Yes, sir. Audible, sir. You can start the proceeding to invite the first speaker, Dr. Satyajit Soni, sir.
Okay, sorry. If we can start now.
Yes, sir. Yes, sir. Please.
Good evening, dear esteemed attendees. It is with great pleasure and anticipation that I welcome you to our seminar on latest updates in lung cancer. As we all know, lung cancer remains to be a formidable challenge for us, but through collaboration and education, we can make a significant progress. I am excited to have gathered experts to share the most recent developments in research and therapies. I extend my gratitude to our distinguished speakers, organizers, and all of you for joining us in this important endeavor. I encourage you all to participate and ask questions. Then, without further ado, I am now inviting our first speaker, Dr. Satyajit Soni sir, to deliver his talk on practical approaches to the clinical management of EGFR mutated lung cancer. Dr. Satyajit is working as an assistant professor in Department of Medical Oncology at Shri Ram Cancer Center of Mahatma Gandhi Medical College and Hospital at Jaipur. Over to you, sir.
Thank you. Thank you, Dr. Arpit, for inviting me for this session. Should I share or you are sharing from your side?
As per your convenience, sir.
I'm sharing. Okay, please move on. Next slide, please. Good evening, everyone. I'm going to present a practical approach for EGFR mutant lung cancer. First of all, with introduction, slide has showing the incidence of the lung cancer, and this slide seems to be old data from zone 18 Globocan, which showed incidence-wise lung cancer is the most common worldwide cancer, and while mortality is again first most common malignancy, which is more lethal malignancy. If you talk about recent data, then if you see incidence of overall world, then lung cancer in the male, it is first most common malignancy. If you talk about both sexes, then it is second most common malignancy in the worldwide. But again, mortality wise, it is first most common malignancy. In India, talk about this. So lung cancer is the second most common malignancy in the male after the oral and lip cavity. Lip and oral cavity, sorry, and the fourth most common malignancy, including both sexes in India. Next slide, please. So next slide, please. So we talk about EGFR mutation positive NSCLC, an overview. We all know that EGFR mutation is more common in the Asian countries versus the non-Asian countries. In the average, it is 30 to 60% positivity rate in the Asian patients and In non-Asian patient, it is 15 to 20%. Next slide, please. And most common EGFR mutations are exon del19 and L858R. So how to use best drug first line, which maximize the benefit for all EGFR mutation positive patients. So various first line options are there, including all third generation, second generation, first generation EGFR TKI. The next slide, please. So first of all, we will talk about third generation TKI as it has shown in trials maximum benefit. So osimertinib is a new standard of care for first line therapy in the patient with EGFR mutant advanced NSCLC patients. Next slide, please. As our NCCN recommended, we see NCCN recommendation, the osimertinib has been given as preferred recommendation in the first line treatment of EGFR mutant metastatic NSCLC patient. If we see patient comes to us and with he or she diagnosed with EGFR mutation at the time of starting of systemic therapy, before the prior to the first line systemic therapy, should start as preferably we should start with third generation TKI upfront. If patient has already started on the first line systemic therapy and during the course of the treatment he found to have EGFR mutation positive, so we can discontinue the chemotherapy, systemic therapy, and we start with EGFR TKI, preferably osimertinib as a first line, or we can continue the planned systemic therapy followed by maintenance with EGFR TKI. Next slide, please. Next slide, please. So osimertinib is structurally distinct from the first and second line generation EGFR TKI. As well, first generation TKIs are the reversible EGFR inhibitor, and second and third are irreversible EGFR inhibitor. And first generation TKI acts against the EGFR sensitized mutation only. But if you talk about the second line, afatinib, again same activity with irreversible inhibitor. Again, it acts against some uncommon mutation. And third, if you talk about osimertinib third generation, it has activity against the T790M resistance mutation also. With ability to, we talk about ability to cross blood-brain barrier, then there is a significant benefit with osimertinib, as it is only drug which can cross blood-brain barrier. Please next slide, please. So the osimertinib, as no third generation irreversible CNS active EGFR TKI, developed to selectively target both EGFR sensitizing and EGFR T790 resistant mutation. As the diagram is also showing same, that is acting against EGFR mutant and T790M, but not the wild type EGFR. Next slide, please. The FLORA trial was the first trial which had shown the benefit of osimertinib against the first generation TKI in the metastatic NSCLC patients. Key inclusion criteria were with good performance status of 0 or 1 with exon 19 deletion and L858R mutation without any prior systemic therapy or EGFR TKI, and CNS metastasis brain mets patients were allowed also, and they were stratified according exon 19 deletion, L858R mutation, and Asian versus non-Asian. The primary endpoint was PFS, and second endpoint was overall survival, and along with that, over objective response rate, disease response, duration of response, disease control rate, and safety profile. Next slide, please. So osimertinib demonstrated significant improvement in the PFS. You can see there is a median PFS nearly 19 months with osimertinib versus nearly 10 months with first generation TKI with healthy hazard ratio of 0.46. So it is showing that PFS is a direct measure of this osimertinib drug benefit, and FLORA was powered for progression-free survival. Next slide, please. If in terms of PFS, all in subgroup, all patients, each and every patient in the subgroup had shown favorable benefit with osimertinib. Next slide, please. If we talk about overall survival in final analysis, we can see the 2-year overall survival is 74 versus nearly 60%, and the 3-year OS is 54 versus 44%. If we talk about median overall survival, it is nearly 39 versus 31 months in against osimertinib versus first generation TKI. So median overall survival is more than 3 years, and patients with the osimertinib were more likely to alive at 2 and 3 year landmarks. And first time an AGFR TKI translated PFS to significant OS benefit. Next slide, please. And we can see the third one graph. Osimertinib patients on osimertinib after the 3 year of the study, nearly 1/3 of patients were continued with osimertinib. Were on the osimertinib as compared to first generation TKI, only there is less than 10%, 9% of the patients were on the first generation TKI after 3 years of the treatment. Next slide. And time to first subsequent treatment, it is 25, nearly 26 months as compared to nearly 14 months in the comparator arm. Next slide. So this bar diagram is showing various trials of using first generation, second generation, third generation TKIs, showing the PFS is maximum in the FLORA study with osimertinib 18.9 months, which is far more than the other first generation, second generation TKI. Next slide, please. If we talk about osimertinib, efficacy of osimertinib across all clinical subgroups, we are already shown the PFS, so good PFS benefit with across all subgroups, and again in the overall survival, it is also showing good benefit. In some of the population not showing that much benefit, which is crossing the midline, the central line. Like non-Asian were shown more benefit than the Asian patients, and and the exon 19 deletion were showing more benefit as compared to the L858 beta. Next slide, please. So, in conclusion, the osimertinib is the PFS benefit was clearly maintained consistently across all subgroups, demonstrating its superior benefit across all population, including by race and across the different mutation types, which is the important as we discussed OS subgroups. All OS subgroups showed a positive benefit in favor of osimertinib, although magnitude of benefit was varied. And this is the consistent with PFS data, which all subgroup favored osimertinib. Next slide. First generation TKIs. There are some Indian studies showing they used gefitinib or erlotinib in the first line setting. Some Mumbai-based studies like Patil et al., Parikh et al. That in Patil et al., EGFR mutant patients with first line in gefitinib in the first line setting, PFS was nearly 8 months and overall survival was 18 months with response rate of 63.5. In first line setting, Lewis et al., gefitinib 10-month PFS and 10-month OS because of there were patients with poor performance status. And again, Noronha et al., 10 months PFS with 21 months of OS with overall response rate of 74%. So median PFS with EGFR TKI in the Indian patient is similar to that reported in the global studies where the IPAS trial and this also nearly 10 to 13 months of PFS in the first line TKI. Next slide, please. We talk about second generation TKIs, then the osimertinib. Next slide, please. The study design here, the study design of Archer 1015 versus FLORA was compared, and the Archer 1050 was phase 3 open label study, evaluated the efficacy and safety of dacomitinib versus first generation TKI gefitinib in the first line with sensitizing EGFR mutation positive patients, and randomized stratified accord randomized in 1:1 ratio with the stratification with the EGFR mutation type status and the race Japanese versus Chinese versus other East Asian and non-Asian, with primary endpoint of PFS and second endpoint of OS, overall response rate and duration of response and safety profile again. In the same in the FLORA, it is randomized in osimertinib versus first generation TKI, either gefitinib or erlotinib, with stratified according to mutation type and the race with Asian versus non-Asian. And the PFS was the first endpoint, primary endpoint, and overall response, objective response rate and OS was second endpoint. You can next slide, please. So we are highlighting the difference in the study design. The Archer 1015 had excluded the brain metastasis, and Flora included the patient with brain metastasis. Next slide, please. If we are showing the KM curve showing efficacy in terms of PFS, and Archer 1015 curves has started to get separated at the 6 month, but in the Flora it got immediate separation both third generation TKI versus first generation TKI arm, and the median PFS was 14.7 months in the dacometinib versus dapitinib. It was 9.2 in the Flora. It was nearly 19 months versus 10.2 months with hazard ratio of healthy hazard ratio of 0.46. Next slide, please. If we talk about overall survival, as the study design of Archer 1050 as hierarchical study design, but overall survival and overall response significance was not met at the end of study. But in the Flora, it was there was significant OS benefit was there, which PFS was translated to significant OS benefit. Next slide, please. So it is same as earlier. Next slide, please. So all things are compared in the one table form. Archer 1050 and Flora, dacometinib versus osimertinib. Archer 1050 study was open label study and stratified in Japanese versus Chinese versus other East Asian versus Asians, and osimertinib was double blinded study and stratified in the Asian and non-Asian patients. In dacometinib in Archer 1050 study, the history of brain and leptomeningeal metastasis were excluded, but in the Flora it was included. So median PFS are 14.7 months in the Archer 1015, and in the Flora it was 18.9. We had already shown that KM curve separates after 6 months, and here it is got separated immediately. With median OS was 13.4 months versus in Flora study it was 38.6 months. And minimal dose reduction was there in the Flora study, only 3% in the as compared to Archer 1050, where dacometinib had shown not shown good safety profile, and dose reduction was in the 66% of the patients. Next slide, please. The LUX-Lung 7 and Archer 1015. LUX-Lung 7, which compared the afatinib versus dapitinib, had not shown OS benefit, but in Archer 1050, there was numerical OS benefit, but it was not significant as because of hierarchical gatekeeping procedure was used for hypothesis setting. Next slide, please. Next slide, please. So these are the various all 3 trials showing cross comparison. LUX-Lung 7, afatinib versus dapitinib. The KM curve showing separation to get started with at the 12 month, in Archer 1050 at 6 months, and in Flora it is got immediately curves got separated in the term of the PFS. Next slide, please. Next slide. So here we will talk about the CNS metastasis. Next slide, please. As we see the EGFR mutation patient of NSCLC, mutated patient of NSCLC, there is initial response to the TKI. Ultimately, there is a development of the CNS metastasis. And this is the brain is as the sanctuary site for patients with lung cancer for metastasis. So isolated CNS progression can occur due to poor EGFR TKI penetration to the CSF, and blood-brain barrier limits the drug penetration to the subtherapeutic dose, allowing the regrowth of the EGFR mutant disease. Next slide, please. And there are many preclinical studies had shown that osimertinib can achieve significant exposure in the brain compared with other EGFR TKI, as compared to the chemotherapeutic drugs and first generation and second generation TKI. Next slide, please. The effect of EGFR TKI on the CNS metastasis, similarities and differences. Osimertinib has shown high brain penetration similar to other well-established CNS drugs in healthy subject with intact blood-brain barrier who received microdose 11C labeled osimertinib. In the FLORA, both systemic and intracranial efficacy were analyzed, and osimertinib had shown superior efficacy to the first generation TKI for the CNS disease, and efficacy with Viren-Mets were not investigated in the terms of first generation and the second generation TKI in all studies and other studies. So osimertinib is the only EGFR TKI to report intracranial efficacy. In the FLORA, the efficacy of osimertinib was similar in patients with and without CNS metastasis, and fewer new CNS lesions were detected in the osimertinib group compared with the gefitinib or erlotinib group. Next slide, please. In the FLORA trial, osimertinib demonstrated its superior systemic PFS benefit regardless of the CNS disease status at the study entry versus EGFR TKI comparator. With known or treated CNS metastasis, total number of patients are 116, and with shown the median PFS, CNS PFS for osimertinib was 15.2, and the standard of care first generation TKI is 9.6. And without CNS, known or treated CNS, osimertinib 19.1 versus other standard of care 10.9 months median PFS. Next slide, please. And CNS progression. Intracranial PFS at the time of analysis, the median CNS PFS was not reached in the osimertinib arm, and the comparator arm it was 13.9 months for intracranial PFS. Next slide, please. And the CNS progression on the first line of osimertinib versus standard EGFR TKI. Out of 279 patients, 19 patients had CNS progression in the osimertinib, and but out of nearly 279 patients of standard comparator arm of standard EGFR TKI, 43 patients had CNS progression at the trial. Next slide, please. It is an overview of preferred first line treatment for many various patients of NSCLC at the time of diagnosis. Those patients without driver mutation and PD-L1 positive, pembrolizumab is good for patients with Viren-Mets, and for EGFR mutation positive patients, it is osimertinib is a preferred approach, and for ALK rearrangement positive patients, alectinib or brigatinib is most preferred approach to start with. Next slide, please. Tolerability profile of EGFR TKI. Next slide, please. As already shown, this there is a minimal number of patients, those who were on this osimertinib were discontinued with treatment as compared to the EGFR TKI arm, and the favorable safety profile despite of almost double median exposure, it is 20.7 versus 0.5 months. Next slide, please. Again, this is the adverse event summary. Diarrhea was the most common side effect as in grade 1 or all grade, but in grade 3 or 4 it is only 3% in the both osimertinib as well as comparator arm. Rashes and acne were overall was more with first generation TKI compared to the osimertinib, and grade 3 or 4 is also again more toward the EGFR TKI of first generation. And if you're going below, other side effects are nearly comparable, and you go below the transaminitis, which was much more common in the first generation TKI. Next slide, please. So dependent on the adverse event duration and the severity, dose modification of second generation EGFR TKI may be necessary to improve tolerability. In the lung 7, adverse events leading to dose reduction were more frequent in the patient receiving afatinib compared with gefitinib. It is nearly 42 versus 2%. In the Archer 1050, there were more dose reduction in the patient with decomitinib versus gefitinib. It is nearly 66 versus 8%. In the FLORA, it is 4 versus 5% respectively. Next slide, please. It is already summarized in the previous. So next, please. Next slide, please. So dacometinib, it had shown higher incidence of grade 3-4 adverse reactions in the R6050, 67 versus 56%, and the more frequent dose interruption with more frequent discontinuation for adverse reaction in the patients of 65 years or older than in compared to younger patients. And quality of life, we talk about quality of life, it obviously it was better with FLORA study with osimertinib patients with osimertinib. Next slide, please. Again, same, it is favorable for osimertinib versus the dacometinib in the term of quality of life. Next slide, please. The synopsis of what? Next slide. So here we should think about that all patients getting benefit with EGF osimertinib or not. If you use osimertinib as a first line, then all patients get benefit, which was documented in the FLORA trial, nearly PFS of nearly 19 months versus 10 months in the first generation TKI. And if we start with osimertinib as first line, then second line we have to go for chemotherapy only. But if we start with first generation TKI, standard of EGFR TKI like first generation TKI, then there is PFS of 10.2 months. But there is a thing that only 1/3 of patients, there is a chances that only 1/3 of patients may receive the osimertinib as a second line therapy because of some of patients may get symptoms get deteriorated in performance status, may get down 2 to 3 or 4. So they may not receive second line therapy, either EGFR TKI or chemotherapy. And 1/3 of patients were T790 mutation and or either T790 unknown status. We have to start with chemotherapy only. Only 1/3 of the patient, those with T790 patients, we can start with osimertinib. So cumulative effect is longer, but number of patients which get benefit is lesser in the if we start with EGFR standard of care EGFR TKI, this is first line TKI. So it is better to start with osimertinib if feasible. Next slide, please. Next slide, please. It is already discussed. Next slide. Next slide, please. So sequencing of EGFR TKI is only commented in the GEOTEC study, where the sequential use of afatinib followed by osimertinib in EGFR mutation positive NSCLC patients. It is showing the updated analysis of observational study. Next slide, please. Next slide. The GEOTEC study is a retrospective analysis of patient who received afatinib followed by the osimertinib. Total are 203 and median OS was 14.3 months. And 2-year overall survival was 80%. And the GEOTEC study suggested reserving osimertinib for second line after failure of TKI may result in the better OS. In the GEOTEC study, median OS for the patient who received afatinib followed by osimertinib was 14.3 months. Next slide, please. GEOTEC study has high degree of selection bias and it is not representative of broader EGFR mutant NSCLC population, as it was retrospective observational analysis and patient with T790M either negative or unknown status were excluded. Patient died on first line afatinib and the patient could not receive second line therapy were excluded. And GEOTEC study patients had higher incidence of DEL19 mutation, which is nearly 73.5, and it must have initiated osimertinib 10 months before the enrollment, and shorter treatment duration were excluded. And endpoints, time to treatment failure, which cannot be compared to the PFS and include the treatment beyond the disease progression, and OS was exploratory. So it is not possible to draw a conclusion about the relative benefit of sequential afatinib osimertinib versus first line osimertinib without a direct head-to-head comparison trial. It is not possible to predict which patient will benefit from GEOTEC sequence at treatment initiation. Next slide, please. So sequencing of EGFR TKI, starting with prior generation EGFR TKI and then treating those that develop EGFR T790M with osimertinib. This is not optimal clinical care because we are not smart enough to figure out who will get EGFR T790M. Not everyone will be well enough to receive additional treatment. 30% of patients in the both arms should no subsequent treatment. And tissue or liquid biopsy are not always successful because of tissue issue is major thing in the lung cancer. Osimertinib associated with the survival benefit. Next slide. So finally, how to proceed with newly diagnosed patient of metastatic NSCLC with EGFR mutation. Those with common mutation of exon 19 deletion and L858R without CNS metastasis, we can start, preferably we should start with osimertinib. Otherwise, if not feasible, then can go for first generation, second generation TKI or pemetrexed platinum-based chemotherapy along with the first line EGFR TKI. If we found the CNS metastasis at the baseline, then it is preferred approach to start with osimertinib, then proceed. If there is uncommon mutation, either de novo T790, we should start with osimertinib, or other exon 20 extension mutation, we should start with first line with platinum-based chemotherapy, and all other sensitizing uncommon mutation, we should start with afatinib. On progression on osimertinib, we should check if we had started with the first generation or second generation TKI, and on progression we should go for liquid biopsy first for T790. If negative, then should go for tissue biopsy again to check T790M. If negative, to go with platinum-based chemotherapy. If positive, then osimertinib. If we have started already on the osimertinib, then second line option is there is a platinum-containing chemotherapy. On that's all. And osimertinib demonstrated clinically. Next slide, please. Osimertinib demonstrated clinically and statistically significant improvement in the OS. The median OS benefit of greater than 3 years set the new benchmark of osimertinib and provide a window of opportunity for the management of the patients with stage 4 and NSCLC with the sensitizing mutation, reaffirming its importance as the first line therapy. In FLORA is the first time when EGFR TKI is translated PFS to the OS benefit. Nearly 30% of the patients remained on osimertinib at the end of 3 years. All patients subgroup consistently shows positive benefit in favor of osimertinib, although the magnitude of benefit varies in terms of OS. But in the PFS, all patients had shown the benefit, good benefit. With additional follow-up and increased treatment exposure, the safety profile of osimertinib remained consistent with previously reported data. So all these things confirms the osimertinib as the first line standard of care in the metastatic EGFR mutation NSCLC patients. Thank you.
Thank you, Dr. Satyajit sir. You have extensively covered a very broad aspect of the practical approach to the clinical management of the EGFR mutated NSCLC patients. Just a small questions. So what are the factors or the criteria which influences your treatment or selection process of opting a particular EGFR mutated agent or EGFR targeted agent? So
here, in which setting I am working here, there is a main issue is the financial consent of the patients, and most of the patients getting benefit with the government schemes. So it is not feasible for us to start with each and every patient of EGFR mutant positive patients with the third generation TKI. If possible, we used to start with osimertinib. Main issue is financial consent.
Yeah, definitely, sir. If we keep the financial constraints aside, then definitely the amount of the median overall survival and the intracranial response rate is unmatchable with any other EGFR mutation targeted agent, as was achieved by the osimertinib.
Definitely.
Similarly, if we keep the outcome of the FLORA-2 and the MARIPOSA aside, FLORA, that is osimertinib monotherapy, remains to be a standard first line preferred agent for the all comers with the EGFR mutated patients. With this, thank you, sir, again.
Thank you, doctor.
Now, I am going to invite our next speaker, Dr. Satyanarayan. He is a consultant and unit head at Jindal Institute of Medical Science, Hisar, and he is going to deliver a lecture on the molecular biomarker testing in lung cancer. He has a plethora of publications in various international and the national journals, and he has a very good interest in various research activities also. So he will enlighten us about various molecular testing that should be opted in various lung cancer patients. Over to you, sir.
Thank you. Thank you, Dr. Arpit. Just want to give an update. Presently, I am in ICC Congress 2023. So please, so maybe some disturbance is over there, but I will try that it will.
Slides visible, sir. There is some audio problem. Sir, can't audible. Slides are very much visible.
Hello. Hello.
Now fine, sir. Now fine.
Uh, 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 so my presentation in molecular biomarker testing in lung cancer. Next slide, please. So the status of lung cancer in India, as Dr. Satyajit already explained, most of the things, the incidence, biomarker testing in non-small cell lung cancer, and so most of the things already discussed. So please, next slide. So now next slide, please. So based on Globocon 2020 data, the incidence of lung cancer, as we know that it's approximately 5.5%, considering the both sex and all age group. And while in male, the incidence is approximately 8% based on the Globocon 2020 data. Next slide, please. So it is second most common cause in males. Next slide, please. So based on the incidence, mortality and prevalence by the cancer site, so lung cancer is the fourth most common based on the newly diagnosed cases, and on the basis of death in lung cancer, it is fourth in rank, and 5-year prevalence is approximately 5.86%. Next slide, please. So as Dr. Satyajit have nicely explained, various driver mutation in the lung cancer. So on the percentage wise, different, the exon sensitizing mutation is 17%, KRAS mutation is 25%, and out of that KRAS G1C is approximately 13%. The recently approved drug sotorasib target against the KRAS mutation, and other are unknown mutation approximately 13%. Rest all like ELK mutation is 7%, and most of the rest other mutation are between 3 to 5%. Next slide, please. So the important biomarker testing in non-small lung cancer, that the main importance, as we know that based on the molecular biomarker study, the patient have available most of the targetable therapies. Based on that, due to the more targetable treatment, that leads to the improved outcome based on considering the PFS and OS benefit, and due to the better targetable, it have less side effects than the toxicity than chemotherapy toxicity. Next slide, please. The guideline recommend the routine biomarker testing for different guideline, like based on the ESCO, NCCN, and ESMO, and CAP guideline for the different biomarker testing. The most common biomarker testing, which usually we do in our clinical practice, that is EGFR mutation and ALK mutation and ROS1 rearrangement, and also to considering the recent therapy, the KRAS mutation testing also recommended, and PDL1 expression is also done in our routine clinical practice. So beyond these testing, we have another available testing for the BRAF mutation, MET exon 14 skip mutation, RET gene fusion, and TRK gene fusion. Next slide, please. So there are different methods for the testing in the non-small cell lung cancer. These are the DNA sequencing, NGS based and PCR based, that detect the deletion, insertion, point mutation, and also detect the RNA sequencing panel that detect especially the fusion based abnormalities, especially for ALK, ROS, RET, and TRK. The IHC or FISH based, that is detect ALK and ROS. Next slide, please. And also based on IHC, PDL1 testing can be done. The evolution of biomarker test in non-small cell lung cancer, the past to current scenario. Next slide, please. So the tissue journey starts from biopsy to analyze. So that is the initially either based on the tissue which is resected after post-operatively. Recently, in post-op status, the EGFR and PDL1 testing are recommended. EGFR testing, especially if patient is 1B onwards, or PDL1 testing if patient is 2A onwards. And recently, the trial have approved the ALK-based treatment also. So now we usually do in adjuvant setting the EGFR, ALK, and PDL1 based setting if patient is 2A onwards, and if patient is 1B, then the EGFR testing is recommended. And as already discussed the methods of testing. So next slide, please. So the biopsy testing, which establish the diagnosis, determine histologic subtype, and biomarker testing. The histologic subtyping, whether patient is squamous or non-squamous. For biomarker testing, primary tumor and metastatic lesion equally suitable. Whether the bone biopsy can be suboptimal due to the decalcification, degradation of the DNA. So another method is liquid biopsy. Through we can do by the cell-free DNA in the plasma, or another option for the testing. Test, as already discussed, that EGFR, ALK, ROS1, BRAF, V600E, and TRK, and RET mutation, MET exon 14 skipping mutation in all non-small cell lung cancer. Use of broad NGS based testing to detect most mutation using least amount of the tissue. For squamous based testing, the patient who have young, never smoker or light smoker, or if biopsy specimen is of mixed histology. But recently, few of the guidelines have suggested the equivalent testing, either patient is squamous cell or non-squamous cell based, and test of PDL1 expression to be done in all patients, those who are the second A onwards or in metastatic setting. The completion of testing within the 10 to 14, that is 10 to 14 working days of biopsy recommended. Next slide, please. The ctDNA testing has been potential to applied across all stages of non-small cell lung cancer and throughout the treatment pathway. It can be used for the diagnosis and treatment selection, monitoring of prognosis, response to the treatment, and progression or the relapse of the disease. ctDNA testing overcomes some major challenges associated with the tissue testing. That is the minimal invasive for patient, allowing for serial biopsy if needed. In ctDNA based, in the bloodstream is compromised due to the DNA from all tumor sources in the body, and the captures both tumor heterogeneity as well as the tumor changes over the time. So the ctDNA testing may never replace tissue biopsy entirely, but could have a complementary role to support the treatment selection in patients with non-small cell lung cancer. Next slide, please. So ctDNA based detection may be used to detect MRD after surgery in resectable non-small cell lung cancer. This is not yet we usually do in our clinical setting, but based on the tracer study, 24-hour early non-small cell patient followed by longitudinally after resection. So we will check the physiological, the phylogenetic ctDNA profiling. Out of these, 93% of the patient in this study with disease recurrence were MRD positive, while the 90% of the patient, that is 9 patient out of total 10 patient without recurrence, were MRD negative. So this study have suggested that if patient have the circulating ctDNA after surgery, so there is high possibility of recurrence. Additional studies to assess ctDNA for monitoring treatment response and relapse in early stage non-small cell cancer are going on. In the Tracer X study, ctDNA profiling was able to confirm MRD negativity and detect MRD in patients who relapsed before their disease was picked up by the standard imaging. So this study guides us that it could be the future option for the patient who have high probability of recurrence. Next slide, please. So comparison of tissue versus liquid biopsy testing. So in tumor tissue, the sample acquisition, invasive surgical procedure, while in liquid biopsy, we know only blood withdrawal, that is approximately 10 ml, and it can be done multiple times. Biology correlate with the histology and cellular phenotyping possible. Direct correlate between circulating DNA results with histology or cell type not possible. So more reflective of tumor genomic landscape. And the sensitivity of assay is lower tumor cell content acceptable with sensitive technique, that is 1 to 10%. Very sensitive method required as the circulating tumor DNA may comprises less than 0.1% of the cell-free DNA. Analytical standardization uses existing and validate tissue processing and handling procedures. Standard for analytical performance characteristic of ctDNA have not been yet have any standardized methods. Evidence of clinical utility for the liquid biopsy is very less. So as we know that various trial results are coming out, based on that, in future definitely we will get some positive outcomes based on the liquid biopsy. So next slide, please. Next slide. So as we know, the multiple gene involved in the non-small cell lung cancer, we have already discussed. So, and Dr. Satyajit have nicely explained about the various different treatment options. So next slide, please. So what is the advantage of the next generation sequencing? Next slide. NGS has a number of advantages over a single gene test. As the number of clinically actionable biomarker has increased, the ability to evaluate all non-molecular alteration in a single test has given NGS a major advantage over the conventional, that is single gene based testing. And also if we will do the multiple single gene test multiple times, definitely the cost will increase. So NGS is an effective, cost effective method if patient have no cost constraint. So also the turnaround time, that is also 10 to 14 days for multiple gene, that is NGS based. So we have advantage that we can get all the molecular report of target or targetable or driver mutation based in a single report. So pros of using NGS versus a single gene test: detect a broad range of molecular alteration, while in cons, that high complexity of workflow that require experienced person, those who are reporting. And the pros of NGS, they are new biomarkers.
Hello, sir. Network issue, sir. Your voice is not audible. Not clear, sir. And the slides are also not moving.
Some issue is in slides, I think. Slides are not visible.
Sir, we can share the slides from here
Yeah,
also.
please share again.
We are sharing the slide.
Shall change the slide. Next slide, please.
Yeah, no, thank you so much. Next slide, please. So the technique and molecular landscape in non-small cell lung cancer, that in NGS we can detect the single nucleotide variable as well as copy number variables. Next slide, please. So there are different testing, as we have already discussed, and Dr. Satyajit already nicely explained about all these methods and the different molecular marker. So please skip this slide, please. So the EGFR mutation in lung cancer adenocarcinoma. Next slide, please. So sample types we have already discussed, that in fresh alcohol fixed specimen can be used for the PCR based assay for especially EGFR mutation testing. The cytology samples are also suitable. Cell blocks are preferred over smears, because if the patient have the metastatic lesion and the biopsy post means this slide have shown that discordance between EGFR mutation status between the primary tumors as well as the metastatic sites are rare. So next slide, please. EGFR mutation test in early lung cancer. As next slide, please. So as the NCCN and various study have recommended, which we have already discussed, that 1B onwards to 3A in non-metastatic setting, the usefulness of the EGFR based mutation study is there based on the EDURA study. So next slide, please. Next slide. So in this slide, that what is the benefit of advantage of NGS over PCR? So we have already discussed that single gene study versus the multiple gene study, that is in form of NGS. One study showed that 48.6% of the EGFR exon 20 insertion mutation identified via the NGS are missed by the PCR. Out of 17 most common exon 20 insertion mutation variants, only 4 can be identified by the PCR. So this is also a point of debate, that even in early stage, whether we will go for NGS based or PCR based on this study outcome, this favors the NGS based tissue testing. So next slide, please. ALK rearrangement in non-small cell lung cancer. Next slide. So we have already discussed that in most cases, ALK mutation, ALK study, ALK rearrangement through IHC, it is 93 to 100% sensitive and specific compared to the fish. So previously it was said that first we will do IHC. If it is negative, then we can proceed for the fish based. But nowadays, if as the most of study have confirmed that IHC based testing is approximately 93 to 100% sensitive. So there is no need to proceed through the fish to confirm the ALK status. Next slide, please. And ROS1 rearrangement in non-small cell lung cancer. Next slide. So these are the mutation we will discuss after that. These are incidence of these mutation are less, that is 3% or less than 3%. So if the patient is adenocarcinoma or non-squamous based non-smoker with squamous histology. So if the patient is EGFR, we will do that. If patient is ROS positive, if it's IHC positive, then it should be considered as ROS positive. Reconfirmation by a second method can be done by through the FISH or another molecular assay. If patient is done through the FISH testing and it is FISH positive, then some of the study have suggested that reconsider for the second method, that is IHC based or another molecule based. And if it is negative, then it is negative. Detection of elevated ROS1 protein level by IHC may provide cost-effective screening prior to the confirmation of the FISH testing, because we all know that FISH testing and the IHC based testing is quite cheaper than the FISH based testing. Next slide, please. So the pathway, as we know that the EGFR pathway that will move through the RAS, RAF, and MAC ERK based signaling pathway, that is intranuclear, then cell proliferation and the prolonged survival for the patient, that is loss of the apoptosis, that leads to the further cascades and the progression or the symptomatically disease profile progression. So next slide, please. So BRAF mutation testing, as I have already mentioned, that these are less commonly mutation. So the mutation of BRAF mainly through the V600E mutation, that is present in more than 50% of BRAF mutation cases out of all non-V600E mutation, considering the total BRAF mutation, more than 50%. Overall BRAF positivity is 1 to 5%, and these are commonly in the adenocarcinoma. The method of detection of BRAF is IHC based and PCR based can also be, and through NGS based can be, if the all targetable driver mutation testing is done. Next slide, please.
Sir, sorry for intervening. Need to conclude, please.
Okay. So as we know that the further few testing which are this MET receptor tyrosine kinase and MET exon skip mutation, that is in non-small non-squamous based, that is 3 to 4%, and 20 to 30% positivity rate of these MET mutation testing, that is sarcomatous cancers. Next slide, please. So methods already we have discussed. Next slide, please. RET receptor positivity rate also in non-squamous cell, that is 1 to 2%, and in 10 to 20% in papillary thyroid carcinoma. And testing method, we know that either we can do through the DNA based NGS, but the few of the studies have suggested that increased sensitivity with the RNA based NGS. Next slide, please. Methods already we have discussed. Next slide, please. So testing for the NTRK based testing, the RNA based NGS is more sensitive for the NTRK based testing. Next slide, please. So we know that IHC, FISH, and NGS based testing are the different method for the NTRK testing. Next slide. HER2 based mutation, as it's 3 to 5% only, and mostly the exon 20 in frame insertion are the most common mutation. The main point considering the HER2, that is worse OS, overall survival outcome in the lung cancer different mutations. HER2 mutation and amplification must be identified during the NGS DNA panel. That is similar to the breast cancer. And in IHC used to assess HER2 overexpression, that is seen in the approximately 60% of the non-small cell lung cancer. Next slide, please. So as we know the different treatment paradigms for the different molecular positivity, we have already discussed. Next slide, please. So PDL1 overall expression in non-small cell lung cancer, that is done through the IHC based, and there are different platforms, that is 22C3, DACO 22C3, or SP263, that is Ventana SP263, SP142, and 28/8, that is DACO platform. And the 22C3 based, that is companion diagnostic type, and test all are complementary type. Next slide, please. Next slide, please. So biomarker testing for immunotherapy in non-small cell cancer is a controversial topic. The PDL1 sole current biomarker to guide the immunotherapy, and the tumor mutation burden, former marker for response, not currently used, conflicting correlation with the survival in checkmate studies. MSI high or MMR study are not usually done in different malignancy we use, but for the lung cancer it is not relevant yet. LAG3 mutation possibly related to resistant to immunotherapy, and this will be being studied in various trials. Next slide, please. So conclusion of that biomarker testing in non-small cell cancer have evolved from single gene to the multiplex gene testing. Multidisciplinary meeting help in better understanding of the sample and test requirements. Sample should contain adequate tumor content, that is at least 10% of the testing of the total sample, so that the processing should not be delayed. Ideal TAT is approx 2 weeks, that is 10 to 14 days in a range. High throughput platforms such as NGS can be used to screen several genes at a time to provide results within the estimated TAT. Next slide, please. So oncogenic targets and the testing methodology we have already discussed. Next slide, please. So thank you, Dr. Arpit. Next slide, please. Thank you, Dr. Arpit, and thank you, AstraZeneca team, for providing me the platform to present.
Thank you, sir, for such a outstanding presentation on the molecular biomarker testing in lung cancer patients. You have extensively or comprehensively covered all the key topics. So I have just a brief questions. So in what conditions or the clinical scenario do you find it most appropriate to employ the liquid biopsy in the lung cancer patients in your practice, sir?
Yeah, in my practice, because sometime repeat biopsy or biopsy samples are unable to collect because of the limited resources setting where I am working. So I usually consider for the EGFR testing, especially for the EGFR liquid biopsy for the EGFR testing. So otherwise, in adjunct setting, I haven't any experience of doing liquid biopsy.
Yes, sir. Just another question, sir. So do you opt for the broad gene-based panel testing or the reflex-based testing? Like as we used to do in, yes, sir.
I usually consider mainly because in periphery, the most of the patient are in metastatic setting. I have only 5% approximately patient who are only the localized disease. Otherwise, most of the patients, 90 to 90% are metastatic. So I usually consider for the NGS broad gene based testing methods.
Yeah. Thank you, sir. Thank you for joining us.
Thank you, doctor.
Now our next topic is the overview of the lung cancer. So Dr. Pallavi is going to present it as she is having some connectivity issues. So I will conclude this topic. So I will request the organizer to please share the screens. Please share the slides. Okay, as we have all discussed, we can put it in on the, yeah, okay. We have already discussed the extensive therapeutic landscape of the management of the EGFR mutated patients. Then we have discussed the various molecular biomarker testing in the lung cancer patients. Now, in a retrospective way, we are discussing the overview of the lung cancer patient. Next slide. So as per the Globocon 2020 data, lung cancer is the about 5.5% of all the newcomers of the diagnosed patients are with the lung cancer. And again, it remains to be a most common cause of the mortality in the cancer patients also. Next, amongst the all is next. Yeah, these were the changes in the AJCC 8th edition. The size of the tumor with more than 5 to 7 centimeter is put it in the T3 category. Again, more than 7 centimeter of the lesion is T4. And similarly, the overall staging is also changed. So basically, T3N1 is stage 3A. Remaining M1A is 4A. Similarly, M1B is 4B and M1C is again 4B again. And subsequently, N1 again in the subsequent 9th edition probably, which is being yet tabled. And the nodal staging is further subcategorized, like N1A, single lesional lymph node is N1A, multi-station is N1B likewise. Next. So for the staging workup, these are the investigative tools we usually used in our clinical practices also. So basically, as per the IASLC staging protocol, we can categorize it into three settings. So initially, we used to image the staging workup and the imaging, then the biopsy and all, then the invasive procedure for the proper staging of the patients, which includes the mediastinoscopy and all. Next. Again, for the stage 3, basically the nodal N2 nodal status, that is mediastinal staging. For the purpose of the mediastinal staging, the CT sensitivity is around 55%. PET has a sensitivity of 80 to 90%. So basically, considering the limitations of the imaging for the detection of the N2 stage, definitely the role of the tissue sampling or the invasive mediastinal procedures have their role. Next. So for the occult N2, which is again very important to prognosticate the patient and proper treatment purposes also, the risk factors of the occult N2 is the central tumor again, and the larger the size, the more the chances of the occult N2 remains. Then again, the higher SUV is also shown to be have a higher incidence of the occult N2 metastasis again. Next. So for the mediastinal staging purpose, we can broadly categorize this into like less invasive, which is EUS guided biopsy, or the invasive procedure, which is mediastinoscopy, which includes the conventional VAMLA, TEMLA, and VETSOL, and the other newer imaging modality, newer techniques also. Next. So this is the mediastinal lymph nodal categories, which is again categorized into 14 nodal stations. Accordingly, they are subcategorized into the N1, N2, and N3 stages also as per the AJCC criteria. Next. So basically, recommended technique is EBUS or EUS guided techniques, which have their advantages and the limitations with them also. For the bulky end to basically invasive mediastinal staging is indicated. Broadly, they are categorized into 4 categories: is A, B, C, and D. So the B category, which is the centrally located tumor, we need to do a invasive mediastinal staging. Again, peripherally located less than 3 centimeter tumor, we usually not the invasive mediastinal staging is not recommended. Again, discrete N2, which is PET avid also, we need to do a invasive mediastinal staging. Next. So this is the very well described flow chart or the algorithm, which is there in the ESMO guidelines also. So if a lymph node is enlarged on PET, we need to do a mediastinal, the invasive workup for, we need to actually tissue sampled this thing to prove whether it is positive or not. Again, PET avid can be false positive also in about 40% of the patients. Similarly, if on PET, mediastinal lymph nodes are negative, and then depending upon the other stages, like if it is clinically N1 or N0, we need to do a tissue sampling with the EBUS or EUS guided. Then if the mediastinal lymph nodes are negative in that, then we can directly upfront go for the surgery also, surgical, depending upon the patient's profile, patient's operability, and the resectability criteria also. Next. So these are the various lymph nodal stations that can be accessed with various procedures, like EBUS and TBNA can target the level 2R, 2L, similarly 4R, 4L, and the remaining 7th and the subsequent 10th and the 11th lymph nodes also. Similarly, these are the various procedures which can sample various levels of the lymph nodes with their limitations with them. Next. This is again showing that various non-invasive and the invasive staging modalities have their limitations also, like CT and PET. Their sensitivity is around 55 and 80 respectively. Similarly, the other invasive, less invasive and the invasive modalities like EBUS and EUS have around 90%. And VETS has a very good sensitivity of 99% to detect the mediastinal lymph nodes negative. The status. Next. So besides these, the evolution of the therapies in the lung cancer has been drastically changed from the traditional view where we used to categorize the lung cancer patients into only gray and white, black and white, which is either small cell or the NSCLC. Then the further historic breakdowns developed where we can further categorize the non-small cell lung cancer patient into squamous, non-squamous, NOS, large cell likewise. Similarly, with the advancement in the personalized therapy, we can now categorize these patients, or we can broadly even categorize most of the patients depending upon their molecular status also. Like in Asian subsets, around 35 to 40%, or the Asian populations around 35 to 40% of the patient can have some kind of the EGFR mutations also. Likewise, the other targetable, actionable mutations can also be present in various NSCLC patients also. And similarly, next. Similarly, with the advancement of these personalized techniques and the advancement in the treatment modalities also, the outcome also drastically changed. We can have a landmark of around 5 years in some very selected metastatic NSCLC patients also, with the use of some of the targeted treatments also. Next. So again, it is showing that initially in the 2006 we can have a chemotherapy for all comers of the irrespective of the histology of the patient. Then subsequently with the use of the gefitinib in 2006, then subsequently crizotinib, erlotinib, and then various newer targetable mutations, targetable agents also discovered. Next. Similarly, we can have these kind of the target or the mutations in various NSCLC patients also. Basically, NSCLC recommended at least 8 molecular alteration testing should be done in all comers of the NSCLC patients. Next. Similarly, current guidelines also recommend and the newer data also favors some of the new adjuvant or the adjuvant chemotherapy, and some of the data also favoring the use of the new adjuvant immunotherapy, and subsequently the role of the new adjuvant targeted therapy also evolution subsequently. So if in the pathological stage 1A, after the surgical workup or the surgical management, observation is being recommended. Then in 1B onwards, the role of the adjuvant chemotherapy, and then depending upon the targetable mutation, like if it is EGFR mutated, we can have the role of the adjuvant osimertinib also, and the role of the other immunotherapy as was in the Pacific trial, and the role of the ELK is also evolutionary subsequently in various trials also. Next. So basically, after initial treatment, more than half of the patient with the resectable NSCLC experiences recurrence within 5 years. So after the initial surgery or the initial management, including the CTRT also, most of the patients, they subsequently recurred either locally or distantly also. So we need to have some kind of the therapies to prevent these recurrences also. Next. So we have seen that there is a data supporting the role of the adjuvant durvalumab, as was depicted by the Pacific trial after the surgical resection. We have the data from the Pacific R, where we can use the adjuvant durvalumab after CTRT also. We have the data from the ADAURA trial. We have the data from the ELENA trial. So basically, there is plethora of the findings or the trials has been going down for the role of the various targeted or the immunotherapy to prevent the subsequent recurrences also. Next. Then comes the very first LACE meta-analysis, which has shows that with the use of the post-operative cisplatin-based chemotherapy in the early stage NSCLC patient has shown an overall survival benefit with a HR of around 0.89, and absolute benefit was around 5.4 at 5 years. Next. Next. So then comes the very landmark trial, which has shown that the role of the use of the adjuvant osimertinib for 3 years post resection after adjuvant chemotherapy has shown a significant advantage in the median DFS, and very recently also shown an advantage in the median OS also, with the very impressive HR of 0.20 in the patients with the stage 1B onwards. Basically, they have enrolled the patient with the stage 1B, 2, and 3A with EGFR mutated patients. Particularly, they have only enrolled these two EGFR mutated patients, which is exon 19 deletion and L858R mutation. Next. Again, there is a trial IMpower 010, which has shown the role of the adjuvant atezolizumab, which has shown an improvement in the DFS and the OS in the adjuvant setting also. Next, in the patients who are PD-L1 positive. Then comes the role of the adjuvant radiation. So basically, the role of the IMRT has shown that the survival is in favor of the using IMRT post resection in stage 3 NSCLC patients. And the conformality of these radiations has again decreases the rate of the grade more than 2 pneumonitis also. Next. Then there is the advancement in the conformality of the various treatment, radiation delivery treatment modalities, including the SBRT, IGRT, and so on. Next. So again, to summarize, in stage 1A observation, stage 1B to 3A multidisciplinary team should discuss the role of the observation versus the chemotherapy. In stage 2B, adjuvant chemotherapy and onwards. And then subsequently the role of the adjuvant, depending upon the targeted status of the patient, we need to discuss with the use of the osimertinib or the other immunotherapy modalities also. Next, again, Pacific trial shows a benefit of using this thing, adjuvant durvalumab post resection. Next, Pacific R is again showing the role of the adjuvant durvalumab post CTRT also. Next, so basically, personalized medicine with the use of various biomarker testing or the broad gene-based panel testing. We should identify the the potential actionable target in the particular patient, so that we can offer the accordingly the targeted drug also, which again shows a significant advantage in comparison to the other chemotherapy also. Like in FLORA, with the use of the first line osimertinib as compared to the other EGFR TKIs, has shown a significant median PFS advantage of 18.9 as compared to the other, which was 10.2. Similarly, ALX, JLX also shows the role of the first line alectinib in ALK positive patients with a very impressive median PFS of 34.8. We can imagine that in a metastatic NSCLC patients, the only median PFS reaches to the tune of 34.8 months, and the OS was not reached till the findings has been published. Next, again, various other targeted actionable targets like MET exon 14 amplification or mutation also, which is there in 3 to 5% of the patients, where we can offer the crizotinib, capmatinib. Likewise, RET rearrangement also found in 1 to 2% of the, and it is also found in both the smokers and non-smoker. We can offer selpercatinib, pralsetinib, and cabozantinib in some of the patient also. Again, NTRK mutation, we can offer larotrectinib, entrectinib. HER2 mutation, we can offer TDXT as per the Destiny Lung trial. Next. Similarly, they have all these targetable drugs has shown a significant improvement in the median OS or the survival as compared to the other the platinum-based chemotherapy in these patients. Next, then comes the role of the immunotherapy in various NSCLC patient. Next, the approval started from the 2015. Now we are in 2023, where we have a role of the nivolumab in the neoadjuvant setting as per the CheckMate 77T trial. Similarly, we have the role of the adjuvant atezolizumab in adjuvant setting as per the IMpower 010 trial. Similarly, we have the role of the other pembrolizumab is also used in the neoadjuvant setting along with the chemotherapy as per the certain keynote 961 trials probably. Next, and is in non-actionable mutated patients, immunotherapy has shown a advantage in the outcome also. Next. So these are the various trials. They have shown that the role of the various other immunotherapies in the various subsettings, be it with the early NSCLC or the advanced also. Then there comes the role of the antibody drug conjugates, where they enhances the delivery of the cytotoxic agent in the vicinity of the tumor cells per se. Next, then comes the role of the CAR-T. So to conclude, we have discussed the various management landscape, which is very fastly changing in the NSCLC per se criteria. Then various targeted drugs has improved the overall survival outcome very drastically as compared to the chemotherapy agents only. So with this, I can conclude the last topic, which was the overview of the lung cancer. Now we can start with our last session, which is the case-based discussion. So till now we have discussed, just a minute. Okay. So till now we have discussed various aspects of the lung cancer management. So we have discussed the role of the EGFR. We have discussed the overview of the lung cancer. Then we have discussed the various biomarker testing modalities. Now I am going to invite my esteemed panelists. Each one has their distinguished expertise in their field. And together we will discuss the various framework of the management of the early stage lung cancer patients. So I will invite Dr. Jitin Goyal. He is hello, Dr. Jitin Goyal. He is a senior resident at the Department of the Radio Diagnosis at the Rajiv Gandhi Cancer Institute. Dr. Shankar, he is a pulmonologist. We will have an expert opinion regarding various role of the various modalities for the assessing the mediastinal staging and all. We have my colleague, Dr. Prashad Vasantacharya. Dr. Swati Chugh. He is DNV resident second year at Rajiv Gandhi Institute. Dr. Bhushan Parmar, Dr. Raghav Anand, and Dr. Indu. I think, hello?
Hello, sir.
Yeah. I will start with Dr. Prashad, if he's there. Hello.
Am I audible, sir?
Yeah, audible. So this is the hypothetical case where a 67-year-old gentleman, which is non-smoker, he evaluated for the mild cough. Initially, chest X-ray has been done, which showed a small lesion in the left upper lobe. Then subsequently, CT chest has been done, which has shown a lesion in the apical lobe. Next. So, Dr. Raghav is there?
Yes, sir.
Yeah. So, Dr. Raghav, what are the factors do you take into consideration before assessing a patient with a lung nodule? So, how do you determine the suspiciousness of this of any lung nodule, basically?
Sir, there can be certain patient-related factors, such as the age of the patient, any history of smoking, which is an important risk factor, any history of occupational exposure to various agents, example, patient working in a coal mine or asbestos exposure. There can also be certain radiological factors, like also in the patient factors, we can include underlying pulmonary conditions like asthma or COPD. And the radiological factors, depending on the scan, the location, size, shape of the nodule, then also the whether the lesion is avid on the PET scan or not. Sometimes we find these changes which are non-avid on the PET scan and ultimately are just infective sequelae of old healed tuberculosis or something.
Yeah, very concisely summarized. So, Dr. Jitin, what all the radiological features they are suggestive of, or they are suspicious to do a further workup, particularly?
Hi, boss. Good evening.
So basically, when it comes to the solitary pulmonary nodule in the lung, and if we do a chest X-ray, it is visible, and further it is evaluated by contrast CT and sometimes with contrast CT with PET CT. When it comes to the margins, the well-defined margins, lobulated margins, and sometimes speculated margins. Speculation is the key point that favoring the malignancy in a old age group, and the size of the nodule more than 1 centimeter also favors pointing towards malignancy. Other things, the PET avidity, if the PET avidity more than 3 SUV, it is also favoring towards malignancy. Other things, the patient uh, like uh, uh, adjacent lung parenchyma, if we see other centrotubular emphysema, patient having a history of smoking, then also further adjuvants, that case scenario of malignancy. With in this CT scan, I can see this CT scan is contrast CT with PET CT. So on contrast CT, I can appreciate there is a well-defined lobulated soft tissue nodule. So this nodule has a soft tissue that is showing contrast enhancement. That is also a factor. If it is a nodule is showing contrast enhancement on post contrast image, so it is also a point that is to be considered. Another thing, it is showing hypermetabolism on PET CT. It is PET avid. So in this case scenario, the two features, the well-defined lobulated margins with PET avidity, uh, are the points that are favoring towards malignancy. So next thing should be HP should be advised in this patient.
Yeah, definitely. Very well described. So I wanted to pitch in Dr. Prashad. So in this patient, what other diagnostic assessments do you like to do? Dr. Prashad?
Hello, sir, am I audible?
Yeah, audible. What other diagnostic modality do you want to offer for this patient?
Sir, considering the patient having a localized lesion, apart from biopsy, I'd like to get the organ function parameters like pulmonary functions, cardiac evaluation, and routine hemogram and biochemistry, and EGFR testing on the
But what other extrathoracic imaging modalities do you want to consider for proper staging workup of this patient? So what is the role of the PET CT scan in this patient, and then MRI brain also?
Yes, sir, I would like to get the imaging of brain, MRI.
Absolutely.
Yes.
Okay. So basically, as per I would like to ask Dr. Swati. So what is the guideline to recommend for the MRI brain and the PET CT scan as per the international guidelines? What are the recommendations?
Hello. Yeah. So
Yeah.
yes, sir. So in this patient, so we have to see if the lesion is central or peripheral. Guidelines say that in stage 1A, if the tumor is hello, is it audible?
Yeah, audible.
Yeah. So in stage 1A, actually, we can still think of getting the patient's MRI, whether we want to get it done, but it is always advisable, even in stage 1A, central tumors and beyond, to get an MRI brain for a proper staging workup that should be done. So ideally in this patient, 67-year-old male, non-smoker, presented with cough, there's a apical lesion in the PET CT. I would definitely like to, as Prasad has already described, a complete biochemical profile, a complete blood count, a PFT, a cardiac profile, a PET CT for proper staging, an MRI brain to rule out metastasis in the brain, followed by the biomarker testing on the tissue sample plus an EBUS. So a mediastinoscopy or a EBUS that should be done actually to rule out and to consider for a complete staging workup of this patient.
Sure, definitely. So after assessing the fitness for the resectability, we need to confirm the mediastinal accurate staging of this patient also. So with this, I would like to invite Dr. Shankar. Sir, could you please outline your preferred approach for the tissue sampling? So whether you would like to, so what are the criteria to decide whether to go with the bronchoscopy or the image-guided methods?
Size of the lesion and location of the lesion and the metabolic activity and intervening lung surrounding the lung lesion. All these things will decide which modality to be decided. In this case, it is in apical position in the left upper lobe, and the lesion is surrounded by the normal lung tissue. So CT-guided biopsy will be giving pneumothorax in these patients. Better going through the bronchoscopic technique, especially ultra-thin bronchoscopic techniques, along with radial probe EBUS, we can get the tissues. And newer modalities like navigations, electromagnetic navigations, robotics, and augmented fluoroscopy, these are the techniques available to get these like peripherally situated lesions getting biopsy. But these modalities are not available presently at India widely. So I will be preferring thin bronchoscopy along with radial probe EBUS to get the biopsy from this lesion instead of CT-guided biopsy.
Yeah, thank you, sir. Next slide. So this is the PET finding, this is the CT scan finding, very aptly described by Dr. Jitin. Next. So next, we have done the biopsy of this patient. It came out to be the adenocarcinoma lung. So we have discussed this diagnostic approach. We have done the imaging workup, tissue sampling. We have discussed the labs and the other cardiorespiratory assessment of this patient. So next, sir, again, Dr. Bhushan, please briefly outline your approach to the mediastinal staging.
Actually, sir, for the mediastinal nodal staging, based on the CT scan findings, or the patients can be divided into 4 categories. The category 1 is the group A, where the mediastinal infiltration, there's obvious mediastinal infiltration. The mediastinal is being occupied by the tumor, and the mediastinal lymph nodes, they cannot be seen separately from the tumor. In these cases, we do not need any biopsy or FNAC to prove the mediastinal lymph nodes, and they are taken as positive only. Then the second group is group B, where we have enlarged and discrete mediastinal lymph nodes. In these cases, the chances of false positivity, the false positive rate of is around 40%. So in this clinical scenario, we need to have biopsy or FNAC by any of the method, EBUS, EUS. So basically, we need to prove the mediastinal lymph node here before proceeding to the treatment part. And those lymph nodes which are more than 1 centimeter in short axis diameter, they are considered, they should be sampled. Then, sir, the third group is group C, which includes the patients who have stage 1 tumor, which are centrally located, and also the clinical stage 2 disease. Here, even if here in this setting, if the patients have mediastinal lymph node which are even less than 1 centimeter, that is subcentimetric, but who have enlarged perihilar lymph nodes which are more than 1 centimeter, or a centrally located tumor, which is defined as located in the proximal 1/3 of the hemithorax. In these cases also, we should prove the mediastinal lymph nodes, either positive or negative, by whatever method is employed, EBUS, EUS, or even after, if the lymph nodes are highly suspicious, then we should go for PET, but which is routinely performed nowadays everywhere. So if the lymph nodes are suspicious radiologically and also on PET, but negative on EBUS or EUS, FNA, then we should proceed with mediastinoscopy in these cases. Then the last group is the group D, which includes the peripherally located stage 1 tumor. And with the mediastinal lymph nodes, they are subcentimetric, and the perihilar lymph nodes, they are also subcentimetric. So, and the tumor is peripheral. In these cases, this is the group D. Again, we need not to prove the mediastinal lymph nodes, and they are taken as negative only. So in group A and group D, no need to prove the mediastinal lymph nodes, while in group B and group C, we need to prove the mediastinal lymph nodes. And even if they come out to be negative, then and are highly negative on FNAC and are highly suspicious on CT scan and or PET CT, then we should proceed with the mediastinoscopy. Now, regarding the method of choice, usually the lymph nodes stations 7, 8, and 9, they are accessible by EUS, transesophageal method. And another advantage of this method is that we can also access the left lobe of the liver. Any lesion,
Yeah.
suspicious lesions, the left lobe of the liver can also be accessed.
Yeah, sir. Definitely. Thank you. Very extensively described. Very aptly described, sir.
Yes.
So I would like to ask Dr. Shankar, sir, what is your approach for mediastinal staging? Just briefly describe, sir.
We will be approaching centrally placed tumors, and we will not be doing for a small tumor less than 3 centimeters, and there is no uptake in the PET scan, or if there is mediastinal invasion. In these cases, we will not be doing mediastinal staging. But this case, there is a in this case, if we do mediastinal staging, we will be starting from the opposite side, that is right side, N3 node, and N2 node, that is 7. Then the same side, that is 4L and 10L, 11L. I will be considering all these nodes in the sequence. If we considering, if we have 8 and 9 station node, then we will be inserting the same EBUS scope. Instead of bronchus, we will be inserting into the esophagus, and we will be identifying the nodes at station 8 and 9. We will be taking sampling if it is needed.
Yeah.
So the sampling will be starting from the opposite side, and the final sampling will from the same side. N3, N2, N1 side, we will be doing the sampling.
Yeah. Next slide. So these are the NCCN guidelines. So if the tumor is more than 4 centimeter, we need to do a brain MRI with contrast. In stage 1B, that is 4 to 5 centimeter, it is optional. PET CT scan in all the, irrespective of the size of the patient or the stage of the patient, we need to offer the PET CT in all comers. And again, depending upon the cardiorespiratory assessment of the patient, depending upon the operability and resectability criteria, we need to do a surgical exploration. And then depending upon the final pathological staging, we need to offer the adjuvant therapies also. Next. So in this patient, we do a US. There was no N2 disease. Patient was medically fit. He underwent surgery. Next. This is the final pathological report with PT2N1. Next. There was no extranodal invasion. So, Dr. Indu. Hello. So in this patient, we have done a surgery. Now, do you check any molecular biomarker in this patient or in any other early lung cancer patient? What is your...
We have to look for EGFR, sir.
Yeah, definitely. Dr. Swati, any other biomarker do you need? Do you want to check in the early lung cancer patient?
Okay, so one, yes, I would like to check for biomarkers now because we have NCCN guidelines and ADAURA is well accepted. So they say that in early patients also we have a role of adjuvant osimertinib. I would like to at least test for EGFR, ALK, PD-L1 in these patients. And if patients' finances are not a constraint, and if we can actually do and we have well-preserved tissue, ideally, I would like counsel the patient for a complete NGS. If not, at least these 3 biomarkers I would like to test.
Yeah. Dr. Prashad, what is your take on testing ALK in early lung cancer patient? We have seen the data from the ELENA trial with the use of the 2-year ALK or the alectinib has shown a significant improvement in the DFS.
Yes, sir. I would like to consider testing ALK also.
Okay, so EGFR and PDL1 is undoubtedly we can go for this testing, and ALK is again remaining to be standardized or to be validated also in the early lung cancer patients. Next, so is there any choice of tissue, whether it should be the pre-surgery or the post-surgery? Dr. Bhushan, do you think there is any discrepancy in doing testing from the pre-surgery or the post-surgery tissue? Okay. Next, I don't think there could be any that kind of the heterogeneity present. Next, Dr. Swati. So please describe any role of the SBRT in the early NSCLC patient. So we have a patient with could be peripherally located less than 3 centimeter. We can opt for the SBRT, or any other scenario where we can opt for the SBRT also.
If the patient, ideally a surgery, but if the patient is medically unfit and multiple comorbidities and not willing for surgery, and peripheral tumors, preferably less than 3 centimeter, if not 3, then at least less than 5 centimeters, can be considered for SBRT. But provided the patient should be medically unfit, not willing for surgery, multiple comorbidities, and poor lung reserve. So FEV1 by FVC ratio should be more than 30%. In such patients, we can consider SBRT.
Yeah, definitely. Dr. Indu, any role of PORT? Post-operative RT, any indication, do you know?
Yes, sir. Any margins positive we can consider, sir.
Good. And there are 2-3 indications also. Dr. Bhushan?
Sir, yes, sir. In stage 1, stage 2, completely resected and completely staged disease. If there is heavy nodal, mediastinal nodal burden, then
inadequately sampled
and inadequate. Yes, sir.
Yeah.
Inadequate mediastinal.
Yeah. And the proximal most lymph node, if it is positive, then also there is certain indication for the PORT also.
Yes.
Again, next. Good. So, Dr. Swati, again, Dr. Prashad can also pitch in. The role of the neoadjuvant therapy in the early NSCLC patient. It could be RT,
Yes.
immuno, or targeted also.
So I would actually take up this question. So we have 3 things in this. One, neoadjuvant chemoimmunotherapy, neoadjuvant chemotherapy. One is neoadjuvant chemotherapy. So in bulky nodes, multi-station N2, and to downstage the tumor, I would like to go for neoadjuvant chemotherapy. But with Checkmate 816, now we have data that with nivolumab along with chemotherapy in squamous or non-squamous, we can actually consider the patients. So what we get benefit with adding of immunotherapy is better major pathological response. So I think it was 36 or 37% major pathological response with Checkmate 816. In such patients, I would definitely multi-station N2, bulky tumors to downstage the tumor to make it resectable. I would actually consider these patients for neoadjuvant therapy.
Yeah, definitely. Again, the multi-station disease is an indication, and these settings also shows that early stage lung cancer also have a advantage in terms of the pathological complete response and the major pathological response also. Good. And again, there is a trial, NeoAdora, which is also exploring the role of the osimertinib in the neoadjuvant setting also. Dr. Bhushan and Dr. Prashad, any other comment?
Not that I am
Next.
aware of.
Yeah, good. So we have done the surgery. It is stage 2 adeno-CA. We have done the EGFR mutation testing. So again, Dr. Bhushan, the role of the adjuvant chemotherapy in such patient.
Stage 2, he should receive adjuvant chemotherapy, and in view of EGFR mutation L858R mutation, along with chemotherapy, 3 years of adjuvant osimertinib is recommended.
Yeah, next slide. So we have done the EGFR mutation testing. It came out to be L858R mutation. Dr. Indu, so the role of adjuvant chemotherapy and its rationale also, and what chemotherapy combo do you want to offer for this patient?
It's an adenocarcinoma. So we will give platinum with pemetrexed, sir.
Next slide. Yeah, definitely. Dr. Prashad. So less meta-analysis, role of adjuvant chemotherapy. Okay, Dr. Swati. Yeah, sorry. Yeah, Dr. Prashad.
Yes, sir. This patient will be offered adjuvant chemotherapy, sir, platinum doublet.
Yeah. Although the
Okay.
5-year overall survival was only to the tune of to the delta of 5.4 months only, still guidelines has shown that the platinum based doublet needs to be given for this patient. Next, subsequently, following the adjuvant platinum based doublet, we need to offer the adjuvant osimertinib for this patient as per the landmark trial has shown a significant gain in the median DFS to the tune with a significant HR of 0.20 in all comers. And also, Dr. Swati, regarding the overall survival advantage also.
Yes. So with the adjuvant osimertinib, as shown in ADAURA, this patient is stage 2A. Adjuvant osimertinib had better hazard ratios, better progression-free survival, and definitely now a trend towards a better overall survival also. So I would like to recommend my patient 4 cycles of adjuvant chemotherapy, followed by adjuvant osimertinib for 3 years, as Dr. Bhushan has already said. In these patients, adjuvant osimertinib will also have a better progression-free survival and less rate of CNS relapses later on.
Yeah, sure. Next. So this ADAURA trial has shown that in the AJCC staging of the 1B, 2, and 3A, osimertinib has shown a significant gain in median DFS with the HR of 0.20 in overall population and with the HR of 0.17 in stage 2 and 3A patients. Next. Similarly, other trials was also conducted in this setting where the adjuvant gefitinib, erlotinib has been tried, and they again shows some trend towards the improvement in the PFS, but not as per the tune of the gain in the ADAURA trial. Next. So Dr. Bhushan, in these EGFR mutated patient, what is the common site of the recurrence for these patients?
Usually on TKIs, CNS is sanctuary site because there is inadequate coverage except for the osimertinib.
Yeah, definitely. The lung is again a most common site of the recurrence in these patients. Recurrence in the lung or the contralateral lung or the other side of the other lobe of the lung is the most common site. Then again, the most cumbersome is the CNS metastatic. So again, it is very important to address or to decrease the risk of the CNS recurrence in these patients. So with the use of the osimertinib, as it was shown in this ADAURA trial, only 1% of the patients, they have the metastasis in the brain, as compared to around 10% of the patient in the comparator arm or the placebo arm. Next. So I would start with Dr. Raghav. You have seen the various outcome results of this ADAURA trial. Do you think it is a practice changing, or you would like to wait for some more times for the data mature?
Sir, I would want to wait for the final.
Yeah, you
like
want to
final
see some
things.
more separation, some more distance in the separation of the curve. It should be
Yes, sir.
a straight line. Definitely.
Sorry, sir?
Definitely. It is always better. So various trials has already shown that giving some adjuvant, some kind of the adjuvant therapy, apart from the surgery or this adjuvant chemotherapy, has shown a significant advantage in the survival outcome also. So be it with the ADAURA, ALINA, and the Pacific R, all these has shown, and again the trials in the neoadjuvant settings also shown that some kind of so only chemo surgery is not sufficient. Some kind of the therapy must be or should be combined in these patients at least. Dr. Swati, your opinion? Monday morning, do you want in a patient of the early NSCLC, do you want to offer the adjuvant osimertinib, or you want to again wait for some more data to mature?
So I would definitely like to offer adjuvant osimertinib. I have reasons for it. So now we have a great like phase 3 trial with ADAURA that yes, previous trials with Geftinib and generation 1 TKIs, they were not very well conducted. Rather, the mechanism of action with osimertinib is different. We also say that yes for osimertinib and no for Geftinib, because CNS definitely a sanctuary site. Osimertinib is more potent. It is an irreversible inhibitor, a third generation TKI, and ADAURA is definitely practice changing. Although more data can very well come up, but we have evidence that yes, this improves PFS and now OS also with a better hazard ratio. So I would like to offer my patients osimertinib.
Yeah, definitely. So definitely some data needs to be further mature. So we are also waiting to come to basically the sequencing. So once the disease starts progressing, then starting osimertinib versus to begin with the adjuvant setting or not. So this data should be come into again will give some information regarding the role of the adjuvant osimertinib also. But considering all these kind or the delta of the outcome difference is definitely should be considered. We should consider for this osimertinib at least. Dr. Bhushan and then Dr. Indu, do you think it is practice changing or some other opinion?
Sir, osimertinib is definitely practice changing because because of the added benefit of extra this CNS coverage. So if the patient can afford, it should be considered. Regarding other TKIs, for like erlotinib, gefitinib, they should be avoided if patient is receiving adjuvant chemotherapy. If patient can afford osimertinib, then it should be given.
Yes, sir.
Yeah, definitely. Dr. Indu and then
Yes,
Dr.
sir.
Prashad, then we can conclude the talk.
As mentioned by Bhushan sir and Swati, I think we can, if patient is affordable, we have to prescribe osimertinib, sir.
Yeah, Dr. Prashad, your concluding remark.
I would like to
wait.
No, I would like to consider offering osimertinib based on patients' finances.
Yeah, definitely patients logistic will remain a challenge in the developing countries like us. Okay, so I think it was a very good discussion in the management of the early NSCLC patients. So with this, next. Thank you. Again, I would like to extend my gratitude to all my esteemed panelists and all other speakers also. I would like to thanks to the organizers for their dedication and the hard work. And again, thank you. Any other query can be taken up? We have 1 minute left.
Thank you, sir. Thank you for this opportunity.
Yeah, thank you for joining.
Okay.
So
Thank you.
over, yeah, thank you.
Thank you, sir.
Thank you, Dr. Jitin, Shankar sir, and Dr. Satyajit boss. Thank you. So over to you. Over to the organizers.
So thank you for your kind words, sir, and thank you for everyone who joined this live webinar. So thank you. I would also like to thank our academic partner AstraZeneca, Axiom Labs, and Eisai. So with your permission, sir, we can close the meeting.
Yeah, we can conclude. Okay.
Yes, yes. Okay. Thank you.
Goodbye.
Bye, everyone. Good night.